Good morning. We start the morning session of the second day of the clinical anatomy, and we shall have a panel talk about how medical teaching went during the pandemic. Perhaps it will have like two parts. The first 2 months, I guess, was very similar everywhere throughout the world. But now some classes have already started, some are about to start for the new academic year in most universities. So it's also interesting to discuss how it's going now, I guess. And we have a number of speakers from different institutions around the world. Thank you for being here. For some of you, it's not a very convenient time to be here. And the first is Dr. from the Department of Anatomy and Neuroscience. It's now the Department of Neuroscience, but until recently, Anatomy and Neurobiology at the Washington University in St. Louis in the United States. Hello, Pricor. So participating, we have a long-standing cooperation with Pricor, and especially in recent years regarding the medical teaching, anatomical teaching. So I'm sure I'm looking forward to your talk. You can unmute. You have to unmute.
Can I share my screen now?
Yeah.
Okay. Do you see my screen? Hello?
Yes.
Okay. All right. So thank you for inviting me. I see that the talks that are listed after me are talking about mostly anatomy teaching in the global pandemic. But what about curricular reform for the whole school during pandemic? And first of all, I would like to extend my greetings from the medical community and the medical students from Washington University School of Medicine. This is our big medical campus. And we have already started our new year with the new freshman class. But we decided that many years ago, 2 or 3 years ago, we decided that we will start our curriculum renewal. We were one of the last of the so-called Ivy League schools to do that. And that is the third curricular reform that is underway in the United States. The first one was around 1910, and that was after the famous Flexner report, which basically fired all the professors from many of the medical schools and started to the work in driving the medical curriculum in the United States anew. So why did we need this curriculum renewal? The fact is that in the 20 years since the last curriculum renewal, the world has transformed by technologies, scientific discovery, and our understanding of the educational science role in training of physicians, and also the evolution of healthcare delivery and our understanding of the social determinants of health, which evolved rapidly during the last several years. So the goals of the curriculum were to produce physicians who are leaders in medicine, science, education, and advocacy. And that is stemmed by the enrichment by a culture that supports the diversity, inclusion, critical thinking, and creativity. And our students had to change the face of medicine through discovery and innovation, reimagine healthcare, and educate and inspire generations to come. So these were the goals, the big goals of our new curriculum renewal. So what we did is that we started in 2018 with the revision of the competency-based learning objectives by an advisory board. Then 3 committees were formed, 2 committees with faculty and 1 student, and they were tasked with the ideas, the big ideas, and the implementation of these ideas, given each commission's makeup. And then the curriculum architecture team was built. And then design teams were built that were actually designed over several key pillars, such as basic in clinical science, clinical skills, clinical immersions, systems and society related workshops, and also a committee that is currently, and it will be working in the future on the assessment portion of the delivery of medical education. All these works have been approved by the Committee of Medical Education and the Academics Committee and the Executive Faculty Committees. And curriculum build-up teams were formed to start constructing modules, immersions, and timelines where the students would explore according to their own interests and desires. So that was done during these 1.5 years, and soon we will have an accreditation by the Licensing Committee of Medical Education. So we had to work very, very hard to make everything ready to start phase 1, which we had to do this year. Phase 1, we had to start on the 14th of September 2020, and then work on phase 2 and phase 3. And I'll talk about these phases soon in a couple of slides later. So generally, we knew that our path was very, very long and steep. So we had to basically come from point A to this high point B, but we have to go through this treacherous road. And this is Yanmen Mountain in China. I haven't been there, but I know it's very, very pretty and very picturesque. So we started our works and wanted to first build on our guiding principles. And I would like to outline these guiding principles. And these are based on competency-based curricular structure that will provide standardization of learning outcomes, but also will individualize the process depending on each student's abilities and interests. The other guiding principle was the development of an assessment system that is transparent and continuously incorporating both regular feedback and routine self-reflection of strengths, direction, and opportunities for growth for each student. Then we would like to use maximally effective educational technologies and, most importantly, active learning strategies that diverge a little bit from normal lecture and lab reference. Then we wanted the guiding principle to go into direction so that it promotes relationships between peers, teachers, patients, and systems of care. And this is very important because our students did not get very good education of system of care, and also how they between the different specialties, and that had to be promoted. And also in that note, to ensure integration of foundational clinical and social sciences content through training with progressive complexity in depth, as known as the helical integration. Then the other guiding principle was required required an elective longitudinal curriculum to support formation of identity as an academic leader with skill development in leadership and teamwork, science, discovery and innovation, teaching and learning, and also importantly, social determinants of health, community engagement, and advocacy. So these several points in the bottom of this slide show how intense our focus was on these important factors of teaching and learning. So our teaching had to be competency-based and outcome-oriented, and these are the pillars on which this competency-based and outcome-oriented teaching had to be: foundational knowledge for practice, patient care, interpersonal and communication skills, professionalism, system-based practice, and practice-based learning and improvement. Do you hear me well? Does everybody hear me well?
Yes, I hear you well, thank you.
Yes. Okay, good. So,
Okay.
all right, I'll continue. Okay, so generally, we wanted to work on curricular integration, and we wanted to integrate basic sciences, clinical sciences, health system sciences, professional identity formation, and social and behavioral sciences in each of those phases. The first phase, which we're now in, the first year, already was reduced in number to be able to fit in this transition from one curricular form to another. Phase 2, which is the clerkship phase, where also foundational science has to be reintegrated one way or the other. And then the phase 3 was the Keystone courses, about which I will talk a little bit later. And also we had to work on competency assessment for each of those pillars: foundation, patient care, interpersonal communication skills, professionalism, system-based practice, and practice-based learning and improvement. All these had to be adequately assessed longitudinally and vertically. So where are we right now? We began in March 2018. Now it's October 2020. So basically we're right here and we have a long way to go. So as I said, we phase 1. Finally, there's a consolidation phase where the clerkship will end with 1 week period of revisiting concepts, filling in knowledge gaps, and including assessment, reflection, coaching, and community engagement work. So generally, in 2021, somewhere in this first week of January, the second phase will start, and the students will get into their clerkship, and that clerkship will end about mid-December the next year. Again, during our meetings with the clerkship directors and clerkship leaders, content leaders, and coaches, we're currently starting to discuss how best to introduce that phase, how to coordinate them, how to administer them, what leadership has to be given, how to integrate learning in a coordinated horizontal and vertical fashion, and how assessment has to be improved and implemented. Phase 3, this is the last phase. This is the gateway to specialization. There will be schedules and activities that are tailored to individual passions and career inspiration. This is when the students start to think about their future careers and choose specialties. I have to say that 99% of the students in our medical school go into specialty directly. and less of them end up being general practitioners. All students will be required to complete a 4-week internal medicine sub-internship, so that will be reiterated. Internal medicine will be reiterated. Students will be required to complete a 4-week advanced clinical rotation, which are similar to sub-internship, but there are areas that will be selected by the students according to their future interest. And there will be a 4-week Keystone Integrated Science course, which will provide deep exploration into the science in a broad array of topics, basic clinical, social, health system, etc., etc. And this is when they start thinking and preparing for their board exam, USMLE Step 1, Step 2, and Step 2S. This is a new thing, and this has been actually a development that I think it will start from this year. So the students have to adapt to it and find a time to prepare for the board exams. And generally, this is a usual day of person who is currently doing these rotations. Generally, this is a person who is at a rheumatology consult service, and he has her first patient for the day. Before she sees a patient, she spent time reading the chart, computer, to familiarize herself with the medical history and the hospital course up to this point. Next, she takes the history and the physical exam, so she's a little bit deeper in the exploration of that patient because it's subspecialty here. And then seeing the patient and writing her notes, she presented to the rheumatology fellow or the attending, and they discussed the plan that she will present later that day to the rounds to the attending physician. So this is a typical day of such a person, and all students must rotate in these manners. And this is the overall image of the third phase, which is advanced clinical rotation and Keystone integrated courses. And there are several electives, as you can see, and each are tailored to the wish, the desires of our graduating students. And then they have to undergo a very popular course, which we call the Capstone Course. And this is a refresher of a kind of everything learned so far before they go into the natural world of working by themselves in the community. And this is when the graduation is approaching. And of course, there are ongoing discussions about how this has to be done. And this is a way to do these discussions in real time by using several new gadgets that I learned too. And this is the Jamboard way of putting the discussion together and coming into a common understanding and what will be next and how to. Thank you.
Thank you, Kriko. How long, how many semesters will altogether the whole program be?
Can you repeat the question, please?
How many semesters is going to be?
Generally, it will be 3.5 years. And the first phase will be about 18 months. And we'll graduate in 3.5 years. Compared to the legacy curriculum, it is 6 years short. So this is how how uh, how how quickly they have to graduate.
6 months
So I
short.
have here now. Yeah, it's about 6 months shorter and more integrated in a way that the first phase is 30% basic science, 30% clinical science and clinical integration, and 30% of social determinants of health, where they learn about systems and how to work in groups of medical specialties and things like that, and advocacy too.
Are there other questions? Yes, Panagiotis, good morning.
Good morning.
Can you stop sharing, Pico, please?
Yes, I'm trying to.
It's in the upper part of your screen.
Okay. Yeah. All right. Good. Hi.
Unmute.
Yeah, please. Still.
Unmute.
It should work?
Yes, now it works.
Yeah? Okay. I thought it's very impressive, and the point when the students start 7 o'clock in the morning, how to evaluate and treat the students. This is very good because you give them a lot of responsibility.
That is correct. That is correct. Basically, starting day 3, day 4 in phase 1, they visit the clinic. We immerse our students very quickly in the clinic. The moment we give them stethoscopes, they're ready to go into the clinics.
Yeah, this is very good. And I have another question. I wonder, also during the time of the pandemic now, what I was missing, the keyword about infectious disease. So my idea is about thinking to offer some kind of special course about infectious disease, disinfection, control, protection. This is what the students do and learn and do every day in practice. But I think if it is maybe useful to include this in the basic curriculum. And,
yes,
we teach the people now during Corona about the disinfection procedure, which has long history, and we know that it started 1842, something like this, with a lot of inhibitors, and this may be very useful to teach this in the basic curriculum.
Yes, our module is immunology and infectious diseases. So molecules in society, which is basically chemistry and introduction to medicine terminology, how the body is constructed, basic, without getting back into anatomy a lot. And the second module is immunology, defense systems. And they will spend like 6 weeks learning about defense system. For example, how the neutrophils migrate the blood vessels, how the immunoglobulins are formed, what is the natural immunity. All that will be given. And this is where we talk about lymphatic system in histology. This is when histology is introduced.
Yes, I understand, but the keyword infectious disease. So what I realized during the pandemic that many people started to understand about the transmission of infectious disease. They didn't know before, and also they don't know what virologists are doing, but now it's easier for people who are active in this field, and I mean disinfection, control, and protection. This kind of words. Immunology is little bit advanced for the people.
Yeah, I'm not in this module. construction group, I'm mostly where I'm an anatomist. I'm not a clinician myself, and I'm also a content expert in the neurosciences. But I hear that a lot of COVID-related knowledge will be in here, because generally we have several. I mean, the one of the people who is a vice dean for education is a infectious diseases specialist. He's a virologist, and naturally he will advocate that. And I'm sure that in the objective that will be included. Yeah, I'm 100% sure. It goes without saying.
Thank you.
Yes, Carl?
May I ask a more basic question? Can you give us an idea what is the relationship of students to faculty? I mean, the numerical relationship. If you talk of faculty, maybe something comparable to assistant professor level in Europe?
Well, we have many faculty, actually. We have also the fellows, we have the attendings, and these everybody teaches. And apart from the assistant professors, apart from associate professors, apart from the professors, we don't, as far as our work with individual students, we don't make difference between who's who. It could be that the head of the department can 2 or 3 students to teach them, the same way as another assistant professor will do it. And also some volunteer into coaching, which is an interesting thing that, for example, some students will study how to organize their day, how to shift their attention from one science to another. And they may need somebody to help them. And there are clinicians who are trained as coaches to give them guidance of how to navigate in this medical student world, and to teach each other. And also there's a lot of clinical immersion, a lot of one-to-one relationship between our faculty and the students. And also students from higher courses trying to work with students from first phase 1. So like a big brother thing, but in a different fashion. And they're actually monitor how they do their work. So there's a constant vertical integration between the older students and the younger students. It's very intensive.
Thank you, Grigor.
Thank you.
We now move to the next talk by Ronald Blaze. Ronald is the chair of anatomy at the University Medical Center, Utrecht. This is one of the largest or the largest anatomy department in terms of their specialty section work. They have a lot of clinical collaborations and courses. So thank you, Ronald, for accepting on this Saturday morning. And we are looking forward to your sharing your experience.
Okay, thank you. Thank you, Anton, for the introduction, and thank you for the invitation. Good morning, everybody. Of course, I would have preferred to be in Varna myself at this moment, but the circumstances which make this impossible are also the reason for this nice morning symposium and sharing experiences. So I would like to share some of the Utrecht experiences. So let's go to the screen sharing. So I guess this is visible now.
Yes.
Full screen. Okay,
Yes.
so these are the topics of my presentation. I will start with a brief introduction on the anatomy program in Utrecht. And then the core is about how we do the online teaching and how we can present dissecting practicals at the moment under corona-proof conditions. And I also would like to make a few remarks about motivation and community building among students, which is more difficult in this era, but extremely important. So our anatomy program, I like to compare it to a 3-stage rocket, which means that in the first 2 years, the students learn the basics throughout 2 years in many multidisciplinary courses. And in Utrecht, the students start clinical internships in year 3. So from year 3 onwards, they come back to our department on a regular basis to prepare for certain internships. For example, before starting gynecology, they come back to repeat the pelvis and the female genitals, but also go into more anatomical details. And for those who really want to go in many details, they can do an optional internship at our department, which is mainly dissection from scratch, very extensive. Especially the course on the trunk is very popular. As for the teaching forms, well, nothing special actually. It's blended learning, so we have the lectures, small group teaching, meet the expert sessions, many practicals, including dissections. It means active dissections, but also studying prosected specimens. And we use a lot of e-learning. It comes in many forms, also modules that we have made ourselves. So let's now go to the core of the presentation. And I will mainly focus on how we adapt lectures, the small group teaching, and the practicals in our dissecting room or without dissecting room. So first about the lectures. We have more than 300 students in a year, and we do these lectures via Zoom. And the first thing, which is nothing new to you, you should adapt the lectures, not as for the content, you can keep it pretty much the same, but there are a few different circumstances. So I've been thinking, how can I keep the students' attention? And I'm including 2 things. First, choosing variation and demonstration. I will show you in a minute what I mean by that. And I've been thinking, how can I do the interaction with the students, which you normally have in the lecture hall by asking questions, by giving them a microphone, etc. And then there are a few aspects which are more technically. I mean, how can I deal with the questions by the students? And how can I be sure that everything works fine? Connection, quality. And as for the last 2 points, the key for me is using a moderator. You can see perhaps I'm sitting in my office at work, but if I turn my iMac, I have a moderator sitting in the chair over there. That can be a colleague, but generally I use a 6th-year student. And this moderator gives me much feedback about the quality of the image, of the sound. Also very useful if something goes wrong. For example, during one lecture, my Zoom connection failed suddenly. And on my side, everything looked fine, but the students didn't see me anymore and could not hear me, while the chat still was running fine. So in no time, she noticed and gave me a signal. So I had to restart Zoom, and within 30 seconds, I just could continue. Otherwise, it would have taken minutes before the students were able to tell me that something was going wrong. Also very important, this student or colleague can handle questions through the chat. There's a chat running parallel where students are invited to ask questions. Sometimes it is noticed that they answer questions themselves among each other. But the moderator filters questions. Easy questions can be answered by the moderator himself or herself. And other questions are just answered by me, either during the lecture or after the lecture in the chat and also through the microphone. Then about variation demonstration. This is a slide of one of the lectures in which I learned the first-year students about the abdomen and about the concept of the mesentery, how the intraperitoneal organs are connected. Normally, in a lecture hall, I invite a student as a volunteer to step forward and to play for my small intestine. Of course, this has to be different now, but it's still well possible. So what I do, I just go out of the presentation so they can see my complete head, because watching a PowerPoint presentation all the time is boring. I won't say that my head is less boring, but there's variation. And then I have this towel, which I normally drape on the arm of a student. So I ask, okay, put your arm forward. It's the small intestine. This is the peritoneum, which goes over it. And then, of course, I have to, in this case, to make some connection through a paper clip, as you can see it. And while I'm doing this, my moderator gives me signals. Is it visible? Is it clear enough? So then I can have this concept, double layer of peritoneum, blood vessels in between. And he also understands if I move like this, it is really a long structure, really something different, only this cross section. And if you are a little bit creative, you can just step back. And if you speak up loud, there are many things you can demonstrate. So I'm using this axis, for example, to demonstrate movements, etc. You have to speak up louder. So also signals by the moderator. I demonstrate skulls, pelvises, etc., etc. So that is a nice way of variation and also of demonstration. So going back to the presentation. And then about asking questions. Generally, during a lecture, I'm using this Mentimeter program once every lecture. I think you may know it. If not, just let's try it. So you can make a free account in mentimeter.com. You can ask any question, and there are different ways to go inside the answers. So I will invite you with me to answer. Normally, I just include an QR code, which makes it easy for students. So you take your mobile, you scan the QR code, and then you open the link. And then you can give an answer. So I hope that you did it with me. Is it Plovdiv of Varna, Sofia, or perhaps you think, well, it's too early, leave me alone. Let's have a look at the results. Well, it seems that I'm the only one who's involved now and answering the question. Anyway, normally there's much response from the students. So some additional tips. You also can ask questions in the live setting. So I ask a question and I say, if you know the answer, just switch on the microphone and give a response. And there's always a response. If you have a nice setting, a nice atmosphere, students are there and they will just respond. They dare to answer through the microphone. Second, start early in time to check the connections, image, light, etc. And if I start, for example, the connection 25 minutes before the lecture starts, I notice that some students are already online. And then I play some music to create some atmosphere. The first lecture for the first New Year's, I played some old Pink Floyd from the metal album, Echoes, perhaps you know it. I thought, well, this is nice to start. And later I had some nice reactions from students who said, well, this was a very good beginning of the medical curriculum. You start the computer, you hear some nice music. I said, well, did you know this music? Of course we know Pink Floyd, because it is so good. So it is a tip. Then about the small group teaching, basically not so different than the physical setting, but a few things set the rules together. When I discuss the community building, I will talk about autonomy of students. And it's important to make the rules that you normally set in the small group teaching together. It gives them some free choice and free will. Also, I think it's important to ask them to be alone in their environment, no other people. Teaching is a private thing, especially in a small group where people are discussing, where people are allowed to make mistakes. So it's good if there are no other people in their rooms, which might be disturbing. And community building can be done very well during the small group teaching, and I come back to that in a few minutes. Then about the practicals. When we went into the lockdown in spring, no physical teaching was possible, but the practicals continued. Some of our teachers, also junior teachers, were very creative. The practicals were based on the original manuals, but they added many visuals, were searching for online visuals, came to the department to make pictures and videos of our specimens, and had many online discussions with the students. based on the original manual and the original sequence to make sure that every aspect was being covered. Some of our teachers made so-called Xerte modules. Xerte is free software. You can find it easily, and I will give you just a very brief example. If you search the internet, you can find many pieces of software or whatever, or programs that you can use in an intern teaching setting free of copyrights. For example, this model of the larynx is from Dundee University. You just can use it, you can rotate it, you can zoom, and you can also, for example, have it shown the structures automatically. And this is quite useful. Going out of this model, if, for example, I go to the next slide, BlueLink is also free of copyrights. You can use it. So students are actually asked to go for an assignment. They can go in a smaller room in smaller groups in MS Teams, and then they can find the answers. And as a teacher, you can just visit these separate rooms and discuss what's going on. And after half hour, you can go to a plenary discussion, which works quite nice. A positive experience, because they could not see the 3D specimens, they had to orientate quite well on the two-dimensional images. And somehow this was a positive experience. It was not only about the labels in the images in the atlas, they had to understand what they were seeing and had to convert it to a 3D experience in their heads, which worked well. And the students were really satisfied about these courses, even despite the fact that they chose for it for the dissecting aspect. And fortunately, since the end of August, we were able to organize physical practicals in our dissecting room again. We worked very hard last summer to make our dissecting hall corona-proof, together with the Department of Infection Prevention and the Department of Labor Circumstances and Environment. This is a photograph of a large dissecting room. It's only a quarter of it because the capacity is 80 students. So the first rule is keep distance 1.5 meters. So therefore we had to reduce the capacity to 40 students. This is a map. We made 4 stations. As you can see, we have 5 tables a station with 10 stools, and we measured exactly this 1.5 meter between every 2 stools. We separated entrance and exit. Normally this is the entrance and the exit. We created a separate entrance through the storage of our bodies. Then the students were collected here, taken to their place. So we started filling up here to there. And after the practical, they started leaving the dissecting room here. And finally, these students left. It was not allowed to walk around, but it was allowed to rotate within the own station because we were using prosected specimens and models. Students had to study a specimen and a model, but at a certain stage they had to show it to each other to demonstrate, and also the student assistant, which is an older year student, has to explain. And therefore we were using face shields, so a few photographs of how it went into practice. So this is the separate entrance which leads to the body storage. When they entered, there was a triage, so they were asked for any complaints. And when they had entered, they were handed over a face shield by one of our prosectors. They received cleaning cloth. The blue one is for regular cleaning. The green one is an alcohol cloth for desinfying. And once they had the face shield, they could enter the dissecting room. When leaving, they had to clean it again with the alcohol cloth, and we collected it again. And then they were ready for other students. And well, our experiences were very well. It went well. Well, you had to repeat many times, please keep the distance, because once they're wearing the face shield, they can think, okay, it is safe. It is safe, but not for 1.5 hours. So as much as possible, they have to keep the distance, but there's no problem at all to come closer together to demonstrate particular things to each other. Then finally, a few words about motivation and community building. Of course, the nowadays students are in a difficult situation. When ending secondary school, they were already in an online environment. When starting student life, they were still in this online environment. Student life is brilliant, as you may remember. So what can we do to help them? So there is a self-determination theory which states that when you want to create intrinsic motivation, you need 3 primary conditions. First, students should feel autonomy, should experience free will and free choice. Second, they should experience competence, which means that they have self-confidence and feel effective in what they are doing. And third, they should feel connected to other people. They should be really a connection. They should belong to others, which we call relatedness. I'm not going through all these conditions extensively, mainly on relatedness, but as for autonomy, it's important because you can do this community building very well in a small group teaching. If you imply rules, explain them, make clear why you want these rules, and set most of the rules together. That works pretty well. Make decision about roles and about if you have a break, etc. As for competence, well, I think these things are pretty clear. These are the normal things that you will do in any small group teaching, even in a physical setting. And I would like to elaborate a little bit about relatedness. So to make sure that everybody is participating, it is helpful to give roles. Who will be the chairman? It's not automatically the teacher. The student can play the chairman. Who is making notes? Who is doing the time management? So you can have some roles and have some rotation over the roles. You can ask very clear questions to a certain student if he's too silent. And then I think this is important. This is not directly related to the contents of the teaching, but it's very important to make the community. First, share some personal information, show interest into students. When I have a teaching session, I start at least 10 minutes earlier and I give notice to the students. I say, okay, I will be online 10 minutes before the teaching starts. If you want to share something, if you want just some normal small talk, just feel free to log in and that can be done. The small group teaching is based on preparation, on assignments that they have. Ask them to prepare in duos. Let them search for a buddy. It also increases the community building. Stimulate that they have some sessions outside the teaching sessions, and realize that as a teacher, of course, you're a part of the community. So make sure that you can be approached by the students, how it can be done, and if they send emails, just answer the emails. And if you do that, it can be nice. And well, to summarize actually what I've been talking about. First, of course, online teaching is different from physical teaching, so you need some adaptations, but there are many possibilities, even for the online variants for practicals. And physical practicals are possible under corona-proof conditions, although still different because active dissection is more difficult. A few recommendations. Lectures should be adapted, and the small group teaching is wonderful to create community building. It's good to search for some interaction and also from variation, not only presenting the PowerPoint presentation. Community building is something to be taken care of, especially during the small group teaching. And we were amazed by one thing, because thus far, examination results were better. About 10% of students more than usual passed examination. And if you would ask me for an explanation, I would say, well, perhaps the attendance is very high. They can just awake and start attending a lecture. So attendance was always very high. Second, the real student's life is reduced to a minimum. So they spend more hours at home. Perhaps it's more inviting to study. And anyway, the exam results have really improved. And to quote our famous Professor Cruyff, of course, it's our footballer Johan Cruyff, who was famous in the Netherlands because of his many quotes. And one of his quotes was, "Every disadvantage has its advantage," which was spoken by him in his famous Amsterdam accent. So thank you very much. I hope that I gave a few tips that might be useful. It's generally small tips, but I guess we're all in the same situation. I hope it was useful for you. Thank you very much for your attention.
Questions on this talk? How did you do the exam?
I don't hear much at this moment, to be honest.
Anton was asking about the exam. How do you do the exam?
So the exam is taking place in a physical setting, in a very large building with many rooms, and it's done electronically. It means each person has a laptop provided by university. Tables are at 1.5 meters. They have 2 tables each to make sure that if the supervisor comes to check ID, that there is distance. I go there, and normally they can ask questions during the exam about the contents, or if a question was unclear. I did it as well using the face shield. And so electronically done in a large hall, physical. If students, because that's what happens, if they have complaints, they cannot come to the teaching and they cannot go through to the exam. It can be done by proctoring. So we have a proctoring agreement, which means that they are checked in the home setting by 2 cameras. And it's not checked live, but afterwards. So after the exam has been done by the student online, in the same time slots as the complete group, some people, they check the recordings which has been made by 2 cameras to see if there's any indication of fraud. And well, perhaps if half of the students is in this situation, it might be difficult with 300 students, but with a few it is feasible. Of course, we have to wait how the circumstances develop. Until now, it goes well.
Other questions?
I have one question.
Yeah.
Okay. The point with the moderator, you show that someone, it's an excellent point that because sometimes if we don't have assistance from the IT department, then we are lost. Can happen that the lecture, you cannot continue something like this. So you have a very good point regarding the moderator, but it is necessary to have a specific person to be there and all the time to follow. It means double staff at the end. It is also a question about this, yeah? But it's very helpful.
Yeah, it is. It works quite nice. And to be honest, it's also nice. Well, I give the lectures in my office environment at work. Well, I have to be here often anyway, because also research is continuing and there has to be a senior researcher present anyway. And well, I have a large office, so the distance is not a problem. And it's more convenient to have someone near to you. It's cozy, yeah.
Is your language, the teaching language, is in Dutch? Or?
Yes, it is in Dutch, yeah.
Ah, okay. And how about the medical anatomical terminology? The students, they need to learn all the medical the terms in Latin, Greek,
Yes, it's the official anatomical nomenclature in Latin and also Greek words with the Latin forms. They use English textbooks, and you know the English nomenclature is also official, but it's a kind of adaptation of Latin, and they get used to it very quickly. We have an interesting thing in Holland, because I think as in many countries, more candidates want to study medicine than we have places. And in 2015, there was a kind of lottery, but nowadays there is a selection, a decentral selection. And our selection takes place in March. It has a really test about anatomy and physiology. And there's also a non-cognitive test. And it means that they have to study from the English textbook. and somehow they get used to some anatomical and physiological terminology. And the first course we have for the first year students is called Form and Function. It's an introduction about the complete human body based on logics and on concepts, but also at understanding. But they also learn many terms. And because they have already some prior knowledge, we can really make a flying start. So in 3 weeks, it's a short course actually, they really learn a lot about the human body. But the official language is Latin. Also, if they go to the practicals in the manuals, we use the Latin language.
I have the problem in Cyprus that many students, they are from US, but they are original from Asia, India, and those go China, in which they never learned, they never had humanistic education.
Yeah.
And I teach before in German universities, and myself, of course, I'm originally Greek, and I know the terms from my childhood, and the Latin I learned this, and it takes me really a lot of energy to convince them that they need to learn, because at the end, if they pass now the exams, at the end they need this later. And I found good the point that you said they need to learn this. So I will transfer this to the students next week.
Sure. Well, I would say the English terminology is fine as well. You know, many people will use English textbooks and articles, and the two languages are basically the same, but in a different order and a few different declinations. So for me, English would be fine. If I will be teaching in the UK or the US, I'm sure I would use the English nomenclature.
Thank you.
Welcome.
Thanks, Ronald. And we go on with Karl Schilling. Karl is the chair of anatomy at the University of Bonn in Germany. And today I just learned that he has a birthday. Happy birthday. We'll have a drink later for you.
Thank you very much, and good morning, everybody. We also have a holiday today in Germany, so I'm doing that from home and not from my office. Right now, I'm still fighting a little bit with. Okay, I got the technical stuff fixed. First of all, I would like to thank Anton for inviting me and for everybody taking part for their attention and time. And I definitely have to give a special thank you to my predecessor, Professor Blythe. It was very instructive. I learned a lot. And probably also because it formalized, it worded some of the experiences I made myself. So I think you will see that some of the topics again. It's experience, organization of dissection room, and this is key issue: how to motivate, how to introduce first-year students into university. Okay, I'm gonna try to share my screen now. Let me see how this works.
Button share in the middle. Lower.
Yeah. Share screen.
Yes, it's working.
Okay, so and now I have just to go like this. Oh. Obviously, allude to the famous novel of Gabriel Garcia Marquez, Love in the Time of Cholera. And as many years ago, this novel took me to new and strange territory of human affairs and relationships. The current need to adapt our teaching and our research to Corona takes me to a new and uncharted territory. It's another level where this illusion actually fits, and that is that this is what It's the one talk I've ever given where I have least data to present. So it's more about random experience, not randomized, but random experience about some feedback I got and some of the plans that we do have. With the first two slides, I want to spotlight the challenge that is both for society and specifically for medical education. So in this slide, I gathered some data on traffic-related death in Germany per month over the past 30 years or so, and of corona-related death per month on average this year. Okay, so there's one good news in the slide, and this is actually this constant decrease of traffic-related death. And I should say that this is mostly due to European Union regulations, not due to German car makership. Okay, but the bad news is, of course, or the news that we have to get used to is that Corona is a much more dangerous situation than riding a bike or a car. The absolute number of deaths due to Corona in Germany has outstripped the number of suicides that we had annually over the past years. And at this moment, or 2 days ago, when I set up these numbers, they amounted to about 4% of cancer death we have in Germany, and almost 3% of those deaths due to heart disease and vascular disease, which are the main killers, so to speak, in Germany. To give a more international view, this is deaths per million of actual US population per month lost in the World War, in the First World War and the Second World War, and some other wars that were fought in between. And I grew up with the Vietnam War on TV every night, so that is a very big impression left that to me. And here you can see how many people, American soldiers, died per month, per million US population. And here we have the current COVID situation in the United States. I selected those two examples because they both make clear, or I think the common to these situations is that as things stand, the fight against Corona is both a medical and scientific problem, but it's also a problem of the cohesion of our society, of collaborating, of taking care and respecting others, and of social coherence that is realized through sensible science-based political action. And I also mention it because in these times, we have a need to adapt our medical capabilities directly to patients. But for most of us involved in early medical training, we have to be aware that we just cannot freeze down, because that would generate problems in medical training and in medical care in years to come. So I think I have a quotation here from Marty Goldhammer, and the main thing is that COVID-19 profoundly affects medical education. So how are we going to deal with that situation in Bonn? Let me just give you a brief basic view of how anatomy is involved, and we're involved in the first 2 years of study. We started out in the first semester, which is in winter, with a pedagogical tutorial. And then in the summer, we have our histology lab, and of course, which is accompanied by a lecture. And much of what I'm going to present to you is the experience we made last summer. In a sense, we were lucky to have only second semester students when Corona took out. Because those students already knew us in person. They also had formed a relationship with other students, and they were not too vulnerable in say social sense. Yeah. Okay. So and we were also lucky because we had in place a digital microscope for some years. So our students do have access to, there's some background noise which is kind of disturbing, but okay, I try to go on anyway. We had this advantage of this digital microscope. Before going into details, I should add one other point. The need to reorganize and to transfer most of our teaching, essentially all of our teaching last summer, into a digital format really presented a major problem for our research activities. And just one example, I had been in Varna last November, and we planned on a joint project with postdocs visiting, say, around April this year, and this all was frozen. But of course, I hope that we can bring back this project to live temperature again. So coming to this virtual microscope, this is accessible through a simple web interface that you can, that students can access 24 hours a day, 365 days from every cell phone, every smartphone, from their computers. And there you can see they can select different folders. We do have one for the classical microscopic and medical cell biology course. We do have one for biology, in the teaching of which we are involved. And we are in the train of expanding it for neuroanatomy and also for gross anatomy. And the technology is comparable to the one you may know from Google Earth. So if you can open up one of these folders, and this is the microscopic anatomy and nerve tissue, and you have a number of slides, and there are actually more than I have on this screenshots. And then you can zoom in, and just to give you one example of histological areas that I'm particularly interested in from a scientific point of view. The nice thing is that you can really zoom in and zoom out like in a real microscope. Students may open up this folder which can bring in annotations or even questions that are annotated, and there's a lot of features to this. Students may add their own annotations, and we can ask them to give us access to their annotations, so you actually can do a interactive histology class with this tool online. Okay, so this course was accompanied by a lecture, and let me just say that one of the main complaints that we got about this course was that the slides were only poorly annotated. This may actually be due to the fact that we blocked out annotations during class, because the basic idea is that the students come prepared that they have read the textbook and they have attended the lecture before going into this class, and they should see the slides like a patient standing in front of them without any labels as to the diagnosis, and they should work on that. And this is quite obviously a thing that we could not make clear, at least not to every student in the online class. And actually one of the main problems I personally had with this online class is that I did not see the board or maybe asking faces of students. You know, I did not get any sensory or very little sensory feedback. And there were only a few students who dared to ask questions or to use the chat. And after a few days, I knew the usual suspects. Okay, and in an online teaching, in a physical teaching environment, I typically can see the students that have problems and who do not dare to ask questions, and I can actually address them. And that's a thing that we have to work on to fix that issue. As to exams were done just as described for Utrecht, not electronically, but in paper form, but in presence, in large lecture halls. And I have to say that the results obtained by the students were in the same range as in the years before. However, among those who failed, there was a larger group that really failed badly. Okay, we do not really know the reasons why. Okay, typically among the students who have real problems here include those which are not native speakers of German. But whatever way we tried to analyze these data, we could not find like a single factor. But as I said, I should add, we have about 325 students, and so this is only one experiment, so to speak. So we do not really know how to interpret these data at this time. Yeah, as I said, one of the main problems in both in lecturing and in teaching online for me was the lack of feedback that I got. I was talking basically to a black hole, and even in questions, there was very, very little feedback. Second point I would like to make about lectures: we did not offer recorded versions of our lectures. Students had asked for that, but according to my opinion, one of the major advantages of a lecture, be that physical or online, is that it gives to students. And there is always a substantial group who works just in time or just in case. And for students coming from high school and having to adapt to the speed and volume of academic learning, this is a very dangerous situation. So we really wanted to use these lectures to force a structure on learning. There's also a substantial number of students who certainly could handle this situation and can structure their days themselves. But I think we also have to take care of those who have to learn that. In support of this interpretation comes a sort of an anecdotal observation. At the very beginning of the semester, we did not have Zoom in place. And so I decided to do a virtual lecturing simply by sending out a reading plan to the students. So I had just had the dates, I had 2 textbooks listed there, and that, well, on this and that date, you have to read from page X to page Y. And I included repetitions typically on the weekend or one of the many holidays that we have in summer in Germany. And I thought this is actually pretty taxing and maybe a little bit paternalistic to the students. It turned out that when we switched to Zoom and no longer continued this structured reading list, quite a number of students complained. They wanted to have this structured list again. Okay. One final thing, I found online lecturing very tiring. So I was more exhausted after online teachings than after physical teaching. And I was relieved when a younger student in our faculty committee shared the same experience that he had from clinical lectures. But as Professor Blythe said, I have to learn to make this more variable and both to keep students awake and not to tire myself too much. So with these lessons learned, how are we gonna organize the winter semester and the gross anatomy lab? How are we? I mean, everybody. It made us think again. What is the goals of a gross anatomy lab? And I think some of the ideas we came across. I mean, these are probably commonplace, but so it should help to recapitulate facts learned from textbooks, but it should also allow the students to relate written text and standard situations to the variability, to the individual variability, even if that's formalin fixed, okay? But it should allow them to make this switch. It should also support the switch from visual textual learning to a 3D experience where they also include additional senses like touch, feel, move. So this is a multimodal kind of learning. But another really important thing, and that relates to the significance of science for anatomy, is that the dissection class should help to sort of reenact, even on a very low level, but to reenact the fact textbook facts were gathered in the first place. And of course, students should learn to translate knowledge into manual procedures and goal-directed action. And finally, I think it's very important that they will learn how to make their own errors, analyze the consequences of the errors, and they should familiarize that very often in medicine, they will do irreversible actions. So that's this active part is really crucial. Now, Nikolai Lazarov showed this nice image yesterday of Rembrandt and the anatomy lesson by Dr. Tulp. And everybody who has ever been in a dissection lab knows that basically such a lab and social distancing are absolute opposites. And this gives you a sneak view of a corner of the dissection lab in Bonn. So we typically have 30 of those tables here with a body on each one. And around each of these tables, we have like 10 students. Okay, so this room is packed. The room has an area of 400 meters square and 1,200 cubic meter volume. Typically, there are about 200 people, students and staff in there at a time in the pre-corona area. And the important thing that you should realize is that the air, fresh air, is coming in from top, and it's evacuated through the tables, and there are additional evacuation air outlets on the floor, which you cannot see on this image. And the air is exchanged about 19 times per hour, at least nominally. So we have a quite high air exchange. And we switched this, our anatomical class, which I've compared here. So here you have again these technical fixes, and traditionally we have 160 students, and each of these students will be twice a week for 4 hours in the lab. And we changed this, that we have less than 42 students in the lab. 3 will be per table, and each student will have an assignment of 2 hours per week. So we go from 8 hours to 2 hours a week. And as shown before, we separated exit routes. Alternative groups will not meet inside the building. Masks are obligatory. The doors will be open, so they don't have to touch doorknobs and stuff like that. And during this time, the students will have a chance to look at prosect material. And actually, the reorganization of this course is only possible because I have well, first of all, very skilled collaborators and about 40 enthusiastic advanced students who do the prosections, but not everything will be prosected. So each of the students in these 2 hours will have to do his or her, and the topics they have to work on, where they have to make their own errors, as I said before, are selected such that they can do it alone. So there's no, you don't need an assistant, so to speak, for that. And they are typically separated so that the distance between students working on the same table is maximized. And this will be then accompanied by 6 hours online teaching, and we're still actively working on this online program. But it will include short movie sequences of how dissection is done in specific areas, and of course it will models and stuff like that. Okay, let me briefly come to summarize who did all the lab, the work. I have to say a thank you to our Vice Dean of Student Affairs, Bernd Pötsch, and to our curricular organizer, Martin Breitbach. I said before that I really have a group of outstanding and very, very engaged students. Let's see, the mother of our cross anatomy lab is Dr. Stephanie Schlieva, and she's whatever ideas we have, she filters carefully for the feasible, and does an excellent job to do together with all the others, and I can't mention all of them. In summary, to summarize that briefly, I think there are in Bonn, we have 4 major challenges coming in the winter. First and foremost, how can we maintain an active research program despite the additional and extensive teaching burden that Corona dumped on us? I do not really have a satisfactory answer to this yet, but I should like to stress that the long-term quality of teaching is intimately linked to our ability to maintain an active research program. If we will not succeed in keeping on to qualify our faculty on a scientific level, I mean, to continue to qualify it on a scientific level, we will have a long-term damage in teaching, in medical training that goes way beyond hopefully way beyond. That goes way beyond the actual pandemic, hoping that we will overcome this. Second, how are we going to organize on-hands teaching? I hope I have given you some examples of how we try to do that in Bonn. And lastly, and this is a point Professor Blythe also, I think I definitely share with him, how will we succeed to integrate the new incoming students and on a teaching and scientific level, but also to give them this feeling of the university community and this switch from high school learning to experience-based active study and building up professional relationships with their peers and growing essentially into faculty. Fourth, and sane to work towards these goals together. I'm optimistic for all of these challenges. After all, we are scientists trained to deal with problems and to solve problems. And in medicine, we also know that it is possible to live with some problems, at least for some time. As I said, I have a number of great colleagues who helped me to go through this and to work towards these goals. And I would like to thank you for your attention.
Thank you, Carl. Ronald has a question.
Thank you, Dr. Schilling. It's very interesting to hear your experiences, and it's clear to me that we share many similar experiences. Also, you were saying that you find it very tiring to use online teaching. Well, I have the same experience, and I also heard it from our junior teachers. And well, there was one day in which I had to do 6 hours of online teaching, 4 hours meet expert sessions, 2 hours small group teaching, and also 2 hours observing a junior teacher. So I was really exhausted after this day. And I've been thinking, why is it so tiring? Well, I think it should be related to the fact that you're just concentrating on the screen all the time and there's nothing else. Well, when you're walking around in the lecture hall, you're watching around, and sometimes you stop talking. If you see students writing, then you can have a small pause and give them the time. And the feedback is really different. That's what I have been thinking about. What do you think of it? Why would it be so tiring? Do you have any particular ideas?
Yeah, I think if I try to observe myself, one thing is I probably feel compelled to talk more than in a physical setting. As you said, yeah. I don't see the students, and this is this constant pressure yeah. to deliver. The other thing is maybe simply both during a lecture and in classes, I just walk around. So, but now I'm sitting on this table, and as you said, maybe for hours, and I well, even if I do research or write papers or stuff like that, I get off once in a while. And of course, this is not really possible in an online lecture. So if we have longer sessions, I typically make some coffee break also for the students, or Yeah, but yeah, I think it's this mixture of feeling compelled to deliver and immobility.
I feel the same, the kind of pressure that you have to continue. It's more difficult to take a break. Well, I think we should try to do it, but it's difficult if there's not much physical feedback from students. I completely agree. Sure. Thank you, Kent. It's very interesting.
Thank you, Carl. Are there other questions?
There's one from Dr. Karanidis, but he has to turn on his microphone, please.
Yes, I try. Yeah. Yes. Good morning. Yeah, thank you for this very interesting presentation. I know the German system because I teach for many years in Cologne. And what I join the opinion also, I am very tired when I teach. What I'm missing, because this is mask to mask, not face to face, it is mask face teaching. And I'm missing the sensory feedback of the students. I don't feel free when I stay all the time on the computer and talk on the computer. I want to see the feedback of the students. One interesting observation I make when I ask questions to the students who are in the lectures, they don't take the risk to give an answer. But all the students from home, when they are online, they give answers. This is very interesting and good answers, actually. But I have two questions. I understood that you don't recommend recording.
Well, I think this really depends on the type of course and the experience of the students. We just decided not to record at the moment, okay? But this is not, you know, my coworkers can do that the way they want. I just, maybe it's an excuse for my behavior, irrational excuse. But as I said, I had the feeling that the lecture also should give a structure to the students. And I think a typical experience we have with maybe about 20% of the students under normal conditions is that they start learning a week before the exam. This is, I think if the lectures would be available online and they start to watch lectures a week before the exam, it would lead to nowhere. And that is something I wanted to suppress. I think with older students who can organize themselves, online availability probably would be an advantage. So I think we have to have a careful view on what to do here.
And the second sub-question about the situation in the dissection room. You said that you have 10 people. We had in Cologne 8. There are 2 more. But now in the new semester, when you start, I think you start in 2 weeks, something like this.
October 26th, yeah.
This work, the students, they should make the dissection by themselves, because you have prosection and dissections. This is a volunteer work for the students, or it is an obligatory work?
It is obligatory. You know, the law requires, actually, we are now allowed to do online teaching in fulfillment of, students are considered present if they take part in online practicals. But we try to do, the 2 hours are obligatory for each student. But as you have been in Cologne, and you know, this is the Rhineland, and in Germany there is always what is called a solution a la Cologne, so to speak. So we make it obligatory, but whether we check presence is a different matter.
Okay.
Because we don't want, to be honest, if you have a common cold, okay, in the old days, you could go to the lab with a common cold. Now, if you have a common cold, you're not allowed to come. You should not come, just to be careful. And we don't want to punish those students that live by infectious disease rules. So we try to keep that as flexible as possible. And we're personally, also it's not completely legal, but personally we switch away from a time-based curriculum to a competence-based curriculum. So if they pass the exam, I don't about the time before. Yeah, but of course we try to stay within the legal framework that we're operating in.
Okay, thank you very much. Yes, thank you.
Thank you, Carl. Happy birthday and happy holiday, national holiday. Now we switch to Dr. Scott Lazaro from Hawaii University. He's the chair of anatomy at Hawaii. It is now 13 hours back in time, so it's 9 p.m. On the previous day in Hawaii. Is it, Scott?
Yeah,
Thank you.
so
Thank you for late time. Please go on.
okay, I'm just going to share my screen here. And okay, well, while I'm getting this going, I just want to thank Anton for this very cordial invitation. Certainly want to thank Roman Sofransky, who introduced me to Anton about a month ago, and Anton introduced me to his wonderful colleagues in Varna. I guess my only regret is that I can't be there with you today. So today I'm going to talk about some of the work we're doing at University of Hawaii in extended reality anatomy, and this is essentially collaborative medical education that goes beyond the dissection lab. I do need to do a little housekeeping here, and my university requires me to read this disclosure. So if you'll indulge me here, Scott Lozanoff and Jesse Thompson have equity interests in RAD3D, and we may benefit from these research results. The terms of this arrangement have been reviewed and approved by the University of Hawaii in accordance with COI policies. So thank you very much. Just very quickly to give you a little bit of background concerning what I do. I'm particularly interested in development of the face, and I look at various genes that regulate facial morphology, in particular the development of the sphenoid. And we've mapped various genes over the years. And one of the issues that we had pretty early on was living in Hawaii, which is about 3,000 miles away from California, which is the next major landmass. We're pretty remote, and we needed to exchange images and models and so forth. So that was really drove a lot of what I'll be talking about today, is this ability to commute or communicate remotely. And in the early 90s, or no, I shouldn't say that. That makes me really much older than I am. I'm pretty old. Really, it was in the early 2000s. At the same time, we were working with these mice and communicating remotely and so forth. We started to apply some of these same techniques to medical education. And again, we're one island of a chain of islands. We have medical students on the other islands. We have medical students that go to the West Coast as well to do internships and rotations and so forth. And we began developing ways to deal with virtual reality over the web. And this is an example around 2005 or so, something like that. You can see the student here with headset on, a virtual reality, what eventually became things like HoloLens and Oculus Rift. And we were interacting with students on other islands, and we were doing this with folks in New Mexico, which is a very rural and huge state. And essentially what we were doing was transmitting cases. So med students were put in front of a patient. This was a fellow that had been hurt in a traffic accident, had a hematoma, and the students had to work through that case. And we did a lot of really original work on transmitting VR images and being able to have students work with one another. Over the years, we've developed that significantly. And what I'll be talking to you today about is a platform that we've developed, which is useful for case development and distribution. So essentially, the idea is that we here in Hawaii will MR scan all our cadavers before they are dissected. And then we take those scans from the hospital, we upload them to a server, and then we've written essentially hardware agnostic software that can work on the phone, your Android phone, your tablet, laptop, what have you. And then we can collaborate and share those images with the students, and then they can collaborate and share with one another from remote sites. So they can essentially look at their cadavers prior to dissection and work with one another to plan those out. As well, we can use the cadavers for a case presentation. So essentially, we can design a case around the cadaver and then present that to the medical students over Zoom, have them go into small breakout rooms, and then work through those cases. So that's what I'll be talking to you about today. The other point to this is that it is hardware agnostic, so you can use it on just about any piece of equipment. We are using primarily ZSpace, which is this console system, as opposed to a headset. A lot of people are using headsets these days. We can run our software on a headset. This is HoloLens. One of the students is looking at a mandible here. But it's a pretty individualized experience, whereas the consoles we can set up next to the cadaver, and then students can work through a lab guide that we've designed with the 3D images and VR images and so forth. So our curriculum is pretty interesting in a way. In the early 90s, our school went from a very traditional didactic approach to problem-based learning, which a lot of schools do now. But at that point, it was pretty new, and it really went way to one end of the spectrum. Essentially, there were no lectures. It was all small group, and the gross lab went away. There was no gross anatomy. And that went on for about 3 to 4 years, and it was pretty bad. It was very bad, actually, because students really, I think there was this belief that students would learn from books, and even then 3D models were starting, or at least some online stuff was starting, and they just didn't know stuff. I mean, they went through their rotations and so forth, and they were complaining to their proctors, and then the proctors were complaining to our dean at the time, and then eventually they relented, and we've gone back to a full body dissection. Now, granted, it's not there aren't huge numbers of contact hours, and the med students are expected to do a fair amount of this on their own, but it is a full body dissection. In the lab, this is a view of the lab here. We have about 80 medical students a year, so it's pretty spacious. And then we've set up these ZSpace machines along the cadavers, so they're banked at each cadaver, and then students can use glasses. And these also are pretty nice because they're really light, and then students can go essentially look through their dissector with those glasses, and also look at their MR scans of the cadavers too, while they essentially know what they're getting into. So we've been doing some case development with the cadavers, but we've also been doing some case development with colleagues. So we're working closely with my very good colleague, Sarah Dahl at University of Heidelberg. And the wonderful thing about Heidelberg, and I'm sure there are plenty of other European universities like this, there is an abundance of old museum specimens. So this is a conjoined twin, and Roman scanned this, and Sarah did as well, and then they sent us the images and then we put it up on our platform, Rad3D, and then we developed a case around it. Now, what I'm going to try to do And I seem to be having a conflict with Cisco, so I don't know if this is going to work, but I'm going to try to bring up RAD 3D, and as we all know, this interactive stuff never works. And it was working pretty well, and then I think there was a conflict, and so this is just the interface here, and the students we have. Sorry. We have organizations and so forth. In other words, we are always looking for beta testers. So if anybody's interested in beta testing, we would really appreciate it. And then we just set up your university for free, and then you can use it. And we do ask for feedback, however. But having said that, I don't think I'm going to have a lot of luck. Yes, this is the conflict. So I might just try to do this. This is the interface. I might just be able to show you the, it's just a less than a minute video, and we developed it here. I'll just kind of go through this, but the, we do the lab, and then you can basically go through the object, and then you can also look at it in AR as well. And you can do this among the students. In other words, the students can look at this, they can chat, they can do this interactively. So it's that kind of idea. I'm just going to try to bring up the conjoined twin. And as you can see, we have many organizations here. Heidelberg is one of them. And like I said, there has been a conflict, so I don't think this is going to work, unfortunately. And essentially, this is the baby, and it crashed. So let me just do one more thing here. Yeah, it's not reading. So I apologize for that. It was working when WebEx started, and then it died once WebEx started. So there's some kind of conflict there. But anyway, just go back to the presentation. We will. Yeah. So anyway, you can go to the object. You can view the object, and then we have this all in Sketchfab as well. And this is the Sketchfab, models. And so from the RAD 3D, you can connect to Sketchfab and then view those models as well. What I might try to do here is go to, hopefully the Sketchfab will work. And I imagine you are all probably aware of Sketchfab, but it's a 3D model system, and we have probably, I don't know, maybe 300 models up here, and I'll just show you some of the models that we're doing with Sarah's group, and you can see that you can do, dissections, you can do artistic models that we've done, and looking for Sarah's model. We've also done segmentations of a number of the cadavers, so we can segment out the cadavers, and then they can see their cadavers as well that are segmented. And just to give you an example, it's this kind of thing. And again, I think you've all seen this. I did want to just show you, though, the work that we're doing with Sarah and Roman as well. And this was the conjoined twin, and we were doing the lungs on this one, and in this case there were two lungs, two sets of lungs. The outer ones were collapsed. And again, with the med students, the nice thing about it is that you can kind of do embryology correlates. So this is the gut model, and it was interesting because, again, on this individual, on the right individual, it had a foregut, midgut, hindgut, but the left individual, the gut was essentially absent. A bit of the foregut, that obviously midgut and hindgut were gone. Big liver that was occupied the entire abdomen. So the idea is that they can go to Sketchfab from the RAD3D, and then they can navigate it in that fashion. All right, I'll go back to the PowerPoint here. And I'll also mention that Brandy Maikami is my student, and she'll be giving a poster on this tomorrow. And there are QR codes on her poster, so she can go through that with you if you'd like. So what we did was we scanned a number of these cadavers, and in the gross lab, we segmented them. This was one individual that was 73-year-old Japanese male. We gave the subject information, we gave the history information that the students could go through, and we break them out into groups. And, they can work through these differential diagnoses themselves, and then they can come back into the main room, and then we can go through it with them to see if they get it right or not. So we give them the subject, the history of the patients, and we kind of make up an exam. I mean, we have their medical records, but we don't really use them. But then we go to radiology findings, and then they click on this, and then they can go to the segmentation and work this in Sketchfab to convince themselves of the anatomical issue. And we've done some survey on this, and this was, pretty qualitative in a sense, but we did this first with just students in Hawaii, and essentially gave them just it was a Likert scale, and the questions that we asked are listed here. Essentially, we were trying to figure out if they're using it, and if they use it, is it engaging, and are they going to continue to use it, because there's a lot of resources that go into this. And we found that the median most liked it. They felt it was helpful in understanding their dissection, and I think it was particularly helpful when they were doing a thorax. The thorax, a lot of the lungs are fibrotic and so forth and difficult to dissect. And that kind of helps them anticipate what they're going to get into. Most of them like the idea that they were viewing their cadaver, and they understood the relevant anatomy a little bit better. Not too many, not a really resounding yes for the use of Z-space, but one of the problems is they didn't have enough time to use it, and that came out in a subsequent survey. RAD3D was not that easy to use, and we're trying to improve the user interface to make a more viable experience. And 97% would like to interactively participate in these different differential diagnostic sessions. Again, they did not use Z-space that much because they didn't have time, and they did use RAD3D a fair amount to view their cadavers. We then did another study with my colleague in Turkey, Güneş Aytaş, and we did a session, a group of Turkish med students. We did a session with them, and then did a group, our session with a group from Hawaii. And this time we did abdomen, and we had a number of abdominal pathologies. Again, we would give them the subject, the history, chief complaint, the exam, and then we could go to Sketchfab and essentially give them visual information as it related to the exam. In this case, there was a large renal hydronephrosis, and we had the segmented model as well, so they could work through that, and they could work through the images. We did a qualitative study on that as well, and that was pretty interesting, actually. We found some significant differences between Turkish students and, we found differences between Turkish students and Hawaiian students. And it just seemed that for the most part, there was more variation with the medical students than with the Turkish students. In some cases, the very light touch on this. In several cases, there was essentially no variation with the Turkish students, and that's where we found some significant differences. The Hawaiian students just seemed to be a bit more variable, a bit more critical relative to what they were using, and essentially these were the questions, and most of it had to do with whether they were learning from it. The third question was, I able to communicate effectively with my breakout group? We found that the Turkish students had, I guess, more of an issue than the Hawaiian students, and that was because the Turkish students were drawn from different medical schools, and that may have had something to do with it. But overall, there was, I think, a positive response, and we can also use this, not only for the in lab activities, but we are now doing using green screen for the online activities. So we've set up a bit of a studio in the growth lab, and we have the green screen, and it's quite remarkable. The images are quite remarkable, and it's a really easy thing to do. I mean, it's technically, it's really not that difficult. You just need, a program. We're using a program called OBS, and it allows you to set the green screen, and then you can project on the green screen, and you can project between cameras to, I don't have it in the image here, but the cadavers here. And then we also have pro sections, so you can go back and forth, and you can put all this on the green screen. And it's a pretty impressive, we've had a pretty impressive response from students viewing this online. So with that, I'd just like to conclude then I'm not sure why I'm not going forward. Yeah, we are putting software on agnostic. Well, we're creating an agnostic platform, so you can use it on with headsets, or you can use it on ZSpace, you can use it on a phone. So students should be able to access this stuff whenever, wherever they want to do it. And I'm really sorry. No. And with that, I just would like to conclude. This was done over a long period of time with a number of people. I just want to thank two colleagues that are working with me right now, Dr. Young Lee from Catholic University in Korea, and Yunus Itek from Ankara. Sarah Dahl and Roman Sofransky have been doing just a wonderful job providing us with these really valuable scans from various cadavers in Heidelberg. And then tomorrow, Brandy McCamey will talk about these conjoined twins from Heidelberg that we're working on, and Nicole Nakamatsu will be talking about the MD6, this online gross anatomy work that we're doing with the differential diagnostic process. And then finally, the Red 3D group, Jesse, McKay, and Evan. So I apologize for some of the technical issues I was having here. In addition to RAD3D not working, I'm using a computer for the first time because my hard drive choked earlier this afternoon. So that was part of the problem, and I apologize for that. Thank you very much.
Yeah, thank you, Scott. It was a pity that some of the software didn't work, but it was a very interesting talk. My question is, you know that there are many models available in Sketchfab, many of them free. On the other hand, there are these more complete body anatomical models which work as a software and which are not free. So what is your feeling about comparing two? So some people just go to Sketchfab and load from there as many models as they can, but they are models which are created by different people. The quality is not the same. On the other hand, you have a standalone software that covers the whole body, but it costs.
Yeah. You know, it's funny because just the other day I was looking at this advertisement for a company that does 3D printing, and they showed a graphic, and they had a picture of the head, and then they had the brain inside the head, and they said, you know, you need to use this. It's wonderful stuff. The problem was the brain was backwards, so the occipital lobe was in the front. So, you know, it underscores the fact that I think what you're saying is that some of this stuff is, you know, the beauty of the cadaver is what was said earlier is that it's a scientific approach, right? The students go in there and they really have to validate things. They have hypotheses, they have to validate it, and there's not going to be a mistake in the cadaver. Whereas this online stuff, you know, who knows who's doing it? Who knows who's making it? With respect to the materials we're using, the 3D models we're using, we make all of those. So I've got a medical illustrator here. We've got a Unity guy. We've got some resources, but we're only using our models. And it's the same thing with. I didn't show really any reality capture cadaver material, but I think some of you folks are doing that as well. You can use reality capture, take 3D photos, and then make the 3D models directly from the cadavers. So I guess the bottom line is we're using all our own models. And so those models I was going through, we've created them here, and I've checked them, and you know, they're pretty good. I mean, we are not doing it commercially. And if you want access to it, just let me know, and I can set you up. I can try to set you up. The one issue with Sketchfab is to try to provide specific images or models to specific institutions. It's like $4,000 for the contract with Sketchfab. So, you know, we'll try to work something out, but we're going to try to make all our models free to anyone that wants them.
Other questions? And if not, the next talk is by the next talk is by Dr. Karanis from Nicosia, Cyprus.
Oh, sorry.
In Cologne, in Germany.
No, I have it fine. Can you hear me? Hello?
Yes.
Okay, I try. Can you see my presentation?
Not yet. We see you, which is nice. But if possible, you could share.
Yeah, but here to try.
The share button.
Sorry, yes. Try again. Coming up.
Yes, it's working.
Yeah. It
Yeah,
should be
that's
visible now. Correct?
Yes,
Okay, then I can start.
yes, please.
Okay. Good morning and warm greetings from Cyprus. We still have about 35 degrees at the moment here. And thank you very much, Anton, and also all of the organizers that invite me to share with you my opinion about anatomy teaching in Nicosia University during the pandemic. My name is Panagiotis Karanis. I am original from Greece. I am German educated. I studied there in different universities, and I was teaching in big universities like in Cologne and in Bonn University, before in Bonn and then in Cologne University. And in the subsequent years, I went for 5 years time period to Japan, and 4 years to China until the year 2018. In the year 2019, the University of Nicosia invited me to join this university and to lead the Anatomy Institute in this university. So my lecture is going, why I have this other people in my screen, do you know?
These are other participants.
Yes,
But we
but
see the screen. We see your presentation.
yeah, it confused me a little bit that this here, the other people are on the screen. I don't know how to take it out.
Minimize the WebEx first of all. Minimize everything.
Minimize the other windows.
Yes, I try, but
The browser and here this one, your email, and then this is your presentation left, right? And now if you start full screen mode, is it working?
controller from.
Yeah, we see now the presentation clearly.
Yes.
I see it too. I see it.
This is now access to my desktop. How can I take this off?
Or if you want, you can show it like this. Like 60% of the full screen.
No, I'm. So someone is now is working at the desktop. Is that Anton or not?
No, you are now out of the full screen, but we still see your presentation.
Okay, I will try. I don't know how to take out this four here, the other four windows. So the University of Nicosia, I will give a short presentation about the University of Nicosia, and then I shift to the part, what are the main changes and modifications have done after March when the lockdown here started, and to what is the topic of the lecture. I realized that more or less we have same experiences regarding the online teaching, and also I feel that I'm tired every time when I do this, but it's different. I feel different when I do this in physical. The University of Nicosia started the first medical school in year 2011. Now you cannot see this because this here screen, okay. I will bring this here. In 2011, by offering the St. George University of London graduate entry MBBS, so master in bachelor in medicine and bachelor in surgery. Building on this, on the experiences with the MBBS, the University of Sofia Medical School is now offering a 6-year MD program designed for high school leavers, and it's offering also a master in family medicine, master in public health, master in science and health services administration for both working professionals and new graduates, and a PhD in medical sciences for research in all disciplines. Nothing is moving. So nothing is moving now.
Just click the next slide.
Yes, I do this, but there's nothing is moving.
Try to exit and enter again the full screen.
Nothing is moving, it's blocked now. Last time it worked very well.
Maybe you just use the arrows on your keyboard to move, the up and down arrows.
I try this, but there's nothing is moving. Yeah, now it's moving. Okay, maybe now it's working. So this was the last slide. I stopped here that I said that the program of the university offered and the facilities of the university. It is still a very young university, since 2011, but this is the largest one, the biggest one in Cyprus, with 13,000 students, and is housed on modern new facilities featuring the latest technology, including state-of-the-art anatomy center and clinical skill laboratories. So it was possible to respond for the IT department to shift from the physical presentations to the online presentations actually in very short period of the time. And the students from anatomy students, the students, medical students, they benefit from gross anatomy laboratory, clinical skills laboratory, which are complemented with histology, histopathology, human performance lab, and a number of microbiology, molecular biology labs, human nutrition and physiotherapy labs. We have always the same problem. The human cadavers are used to teach anatomy because we believe that is the normal anatomy teaching, and it gives value to the students for their medical education. And there is also a very large collection of realistic anatomy models, bones, clinically oriented anatomy guides, and video projectors, screen and sound system for educational and training videos and other useful teaching aids, anatomy atlases and dissection guide. But we don't have the typical museums or exhibitions like I experienced before in Germany, and still I do. This is point it needs to be established. Can you see my slides now? Because I reduced the page, the size. Can you
Yes.
see?
Yeah, it's large enough.
And in the last year, it was an integration of clinical ultrasound in the curriculum of the MD program, which is offered now by our medical school, and it is going in as a complementary teaching now to the anatomy course. It is a part of the anatomy course, so it is in the second year. And this institute tried to offer balanced curriculum which include classroom instruction, laboratory training, and supervised clinical experiences. So this is also in the latest technology offered, and this is very useful, but of course it needs a lot of logistical program, because it's going after the sessions of the anatomy teaching in the dissection room, and this is not easy. The anatomy teaching, it comprises normally in small groups learning that is facilitated by anatomy demonstrators. Most of them, they are clinicians who join the medical school, and they help the students to connect clinically relevant topics with anatomical structures. Our anatomy teaching is really clinical oriented, and we think that this give a deep approach in learning anatomy to the students through their careers. So it is actually the same system which is used in the St. George University in London. In addition, the histology laboratory has been equipped with the necessary resources that support a small group learning model, and the University of Nicosia is an established examination center for the Royal College of Surgeons of England. This offers an advantage also to the alumni who wish to advance their surgical careers. The anatomy curriculum, or the anatomy teaching, underwent a very long period of evolution. As we see here in the mid-age, the anatomy lessons of Dr. Tulp, which in Amsterdam, which were not for the students at the time, it was for people who were prominent in the city. And this anatomy teaching, it has been replaced in the next years, or in our time, with the macro anatomy teaching and the cadaver for the students. This is my situation here in Cologne University, where we had 500 students, or maybe a little bit less now. And in the macro anatomy per semester, 8 students, 1 cadaver, but real dissections. And this is a little bit different in Nicosia now, that we have, this is the dissection room, in which we have students from around the world, from many countries, New Zealand, Canada, and US, UK, and also Germany, also different European countries, but they are smaller groups. They are 5 to 8 students in one cadaver. And the difference is here that they are pro-sections. So this cadaver, they have been transported to the country, and they are used for several years here to teach the anatomy students, where we have different stations. After the lockdown and the COVID epidemic, it was necessary to have a response to these situations. Therefore, technical, academic, and logistical modifications have been realized. And what were the technical modifications? First one, in the room you saw before, we put plexiglass anatomy, and the stations, they are now 6. They have been divided, separated with a plexiglass. Then the anatomy ventilation system, it is a rapid air exchange with outside air. I don't provide now the details, as it was from the Bonn presentation with Dr. Schilling, and we offer 70% alcohol equipment cleaning between the sections, but also personal protective equipment. All of these rules have been discussed with the government responsible people and the people responsible for the university. And regarding the anatomic teaching modifications, we started to offer since March online the standard lectures and the tutorials. So the university already closed, and we still continue to offer this kind of lectures online, but we have now face-to-face or mask-to-face, mask-to-face teaching, but not in the same amount in the same room we don't have the same amount of students. Because here there are some modifications. We reduce the number of the students for the lecture, which is needs a physical presence. 1 week we have the half of the students. There's a certain number of students they are allowed to be in the lecture, and the other part of the students they are at home and they follow this on-site. But we offer also remote learning for students who are not here now. There are several students who didn't succeed to reach the country until now. Maybe at this moment they are 5, and we offer for these 5 students remote learning, teaching in extra house about the sessions which we have before. So there are different stations, and they are each time they are 3 different topics in which the students they rotate. And this make the situation very difficult. In order to keep the safety measures during the practical sessions, we have to make this group smaller. Before I said 5 to 8. 5 to 8, they are also 2 different courses. I said before the MBBS and then the MD course. And the courses, the groups are now smaller, and therefore we have to repeat the sessions several times. And the people, they need to keep distance to each other, 2 meters, and there is only 1 demonstrator in the specific section. So this online anatomy teaching includes also library resources. The students, they have access to electronic books, videos, journals, and anatomy guides. And the third part of the modification to the COVID response was the logistical modifications here in order to keep the safety measures. The students enter the anatomy lab in small groups. The entrance and the exit are different, but we need every time to educate the students to keep the order and to have discipline. Every time is necessary. They forget it, and we need to remind them. So the very small groups, 3 students per cadaver and 1 demonstrator. The students, they have to assign a paper to the attendance is checked before they come in. There is some accumulations in the floor at this time and the front of the door, which need a strong discipline every time to remind the students about the situation. And only 1 demonstrator per station with a 2-meter distance. And randomly, the temperature from the students is checked before the decision is starting. So the take-home messages for the students, what I try to tell them, and I see that I am in agreement with the other professors here who teach in different countries, it is that I try to motivate them from the history. And I use as an example here Dr. William Harvey, who was a professor also in the St. George University, so there is some kind of affiliation between the Nicosia University and his curriculum. And he stated, I learn anatomy not from the books, but from the sections, but from the fabric of the nature, and he means the dissections. He graduated in the age of 24, and he was excellent with his anatomy skills, memory and learning, and I try to emphasize this time, the period when the people live and the conditions they had, on how much anatomy knowledge we offer today, and how much difficult is this for the students that they take example in contrast to the period in which the people were active before. And the other take-home message for the students is that the anatomy is the basic requirement for the good quality of patient care, and they need to do this, they need to learn this, because the opportunity is later difficult during the undergraduate studies. They have some opportunities, but this is the basic course, and at the end, and at least, surgery is applied anatomy. This is what I want to try to tell to the students, and together with this team, the people you see here, there's a group of people, the chair of surgery, ultrasound institute, demonstrators, clinical assistant professors, who share with us the time and the knowledge to teach the students and some others who are associated or clinicians who are osteopathy, surgery, urology, and general medicals, and this is the anatomy center in the University of Nicosia. So I think that that's it. Thank you for your attention, all of the participants, and I write also my mail in the case is good for the contract. Thank you very much.
Thank you, Yaris. Questions? Please stop sharing. I will load the next presentation. Now we have a couple of presentations from the Bulgarian medical school, the anatomy departments in Bulgaria. The first one is from the colleagues from the anatomy departments at the Sofia University Medical School. There it is. Dr. Maslavsky is absent, but his colleague, Dr. Stoikov, will present it. Is here. Please have a seat.
So, dear colleagues, my name is Dr. Mitev, and together with my colleague Dr. Stoikov, we are going to present to you on the topic of continuous education and anatomy during the COVID-19 crisis. Dr. Maslavsky was supposed to be here today, but due to personal issues, he sadly couldn't come. Together with Dr. Stoikov, we will try to best describe the issues that we faced during the first part of the Corona crisis and the goals that we have set as a department for during the COVID-19 pandemic. The current crisis hit healthcare systems around the world and has had a ripple effect in all spheres of life, as we know it. No sector of society has been spared, and some of them have been even brought close to total collapse. Education, as a big part of it, has been basically turned on its head. During the first part of March, mid to late March, so almost all countries around Europe banned in-person education and suspended most parts of in-person educations in most schools. This led to a reorganization of pedagogic strategies. The pandemic was getting students out of the dissection rooms and into their living rooms. And although that some students might have really liked that, a problem arose. How can we adapt to this new environment?
Okay, so here is some chronology of the events in Bulgaria. So the first COVID-19 patient that was positive by the PCR test was in, let me just move this window. Okay. Okay, it's on the 8th of March. Yeah. Okay. And the rector of our university suspended all attending classes. On the 13th of March, a state of emergency in Bulgaria was declared, and all attending classes were suspended indefinitely in both tertiary schools and both secondary schools. So, after a week of complete interruption of the educational process and numerous online councils within the department, the decision was made to restructure part of the educational process in an online fashion. We already had some advances in the teaching methods, and those were seen as a potential solution to the issue. Initially, we started using the platform called Moodle, which is the official online learning platform at the university. This platform has numerous advantages, as you could create and share virtual halls with students, give assignments to them and tests, and even you can check their activity online. As we all are witnessing here, a lot of issues occur with these platforms, and a lot of the issues are actually technical ones. The issues were broadcasting delays, audio problems, and the inability to pre-record materials for the repeated use. And this made us rethink our strategy and try to adapt it. So at this time, we started using software that is free to use, and it's called Screencast. It's something like the OBS, like our students in Varna use. And we use it to pre-record different materials, which then we can use and integrate in other platforms like the Moodle one, also in YouTube Studios. The most important advantage of this tool was the creation of the product that can be used repeatedly in the future. We called it Watch, Read, and Repeat. As we can present new material for the students, they could also catch up on the theoretical materials regarding the issue, and could lastly visit the video materials on their own when they need to. And in the terms of duration, our goal was to keep the length of the e-learning material equal to that of an e-person lectures. Those are some videos recorded by Professor Maslavsky. So we cannot hear him, but okay, there is no audio, as I can see, but I think you get the point. So those are the pre-recorded videos that were sent to the students and were uploaded to the Moodle platform, so they can use whenever they need to. And that was both for microscopic and macroscopic anatomy, the lectures. So for our histology practical courses, we used a mix of in-house prepared materials and online available ones. On the picture below, you can see our beloved colleagues, Professor Diegov and Professor Filipov, which prepared slides and took pictures of them, which we then could upload in our online platforms. We hope that this process continues throughout this year also, so in the end we can have a standalone library coupled together with a theoretical course, which we can use in years to come. The other information source that we used was Histologyguy.com. That's a free-to-use platform which offers great quality slides, which students can easily manipulate, pan, zoom, and use all different sorts of technique to view the parts of the slides that they interest them, coupled together with some very concise and practical theoretical knowledge. This way, the students get access to high-resolution microscopic slides that they could manipulate in different ways. But the major disadvantage that we saw with this approach that we had is that students couldn't learn to use a microscope, obviously. This is just a slide that shows some materials from histologyguy.com. We try to redact and adapt the information that's in this free-to-use website to the needs of our personnel and our teachers. At the very beginning of the crisis, one thing was very clear. The most difficult part of teaching anatomy online was that we couldn't do dissections. We provided e-learning materials to our students, but we knew that
no form of e-learning can substitute the practical knowledge acquired in the anatomical theater. That was one of the main reasons that made us decide to return to in-person teaching as soon as was deemed safe.
So, about the teaching process, it was organized in such a way that we put an emphasis on the practical course. These courses were carried out in the span of 2 months, that's for June and July, in the form of intensified learning to compensate for the lost time. It was decided that the students will work in smaller groups of 4 people, as we heard from our colleagues in Bonn also, and that 4 such groups would work parallel on 4 different cadavers. Every 20 minutes, the students would switch between the cadavers. It was decided that the total time for each class was to be no more than 2 hours. This is 2 hours only for the one practical class, and we gathered together 3 times a week. So that's in a contrast to our colleagues, and opposed to their 2 hours lectures, we did it 3 times a week. So 3 times 2 equals 6 hours a week. And all sanitary preventative measure was seriously enforced in order to prevent viral transmission. That including washing of the hands, and the hand sanitizers are provided and were put in every room of our building. Mandatory mask wearing, a proper ventilation of the dissection rooms, and a mandatory PCR test provided by the university for each student before returning to in-person classes. So our plan for this academic year, as we have already started. So plan A, for this academic year, we're prepared for 2 different scenarios. The plan A is we envision combining the 2 methods of teaching, that it's online and in-person teaching, and 2/3 of the lectures will be prepared and presented in an online fashion, with 1/3 being still in person. The practical courses, as long as conditions permit, will be carried out in an in-person fashion, and all necessary preventative measures will be applied as discussed above. The practical anatomy course will be focused on prosections and clear presentation of key anatomical structures. With the described organization, we hope to both ensure physical distancing and also to increase the quality and efficiency of the class. And about the plan B, we will present a strategy if we return to a full ban of in-person teaching, and in this case, we would have to use the already implemented online platform and teaching strategies. The anatomy curriculum covers 2 years of the entire academic process, which thankfully would allow us to disperse the material and catch up with the practical classes in the next semester or year.
So, although this crisis has already caused a lot of damage, we think that we should try to get the positive side of it. That means one key thing is let's try to combine technological advances with the way we teach and for the students to learn anatomy. So in the University of Sofia, we don't ask the question how, but why, but how. How do we adapt and improve our methods? And how do we keep the ball rolling after this crisis is done, so that we can take the lessons learned today and apply them tomorrow. So thank you for your
attention, and we are very eager to learn from our colleagues how are the practical classes organized in your universities. Thank you very much.
Thank you.
Thank you. Now, Dr. Lazaro from the Medical University of Sofia will present their experience.
So, Mr. Chairman, dear colleagues, first of all, I would like to apologize that I didn't prepare a presentation, but I will try to share our modest experience in teaching anatomy under corona conditions. Okay. As you know, the coronavirus disease pandemic has influenced all aspects of our lives, including education. As a result, a rapid transition from traditional face-to-face teaching methods to online teaching, or a combination of both, has to be implemented. Therefore, online classes have become a key component in the continuity of education. Though they are flexible for both teachers and students, time-wise online classes have their own challenges. Online education turned out to challenge our university because students, teachers, and administrators were not prepared for it. One of the first difficulties we encountered was that no distance learning platform has been available in the university then. Moreover, most, if not all, of the teachers and students had little or no online teaching or learning experience before the pandemic, and therefore learning technology was unfamiliar for both teachers and students. On the one hand, professors who mostly relied on in-person modalities found that shift to online teaching challenging. Besides, some teachers themselves are technophobic. That is, they are worried or not confident enough about dealing with computer hardware and software in their classrooms. On the other hand, from the perspective of a medical student, online classes are not equivalent to classroom experiences due to the lack of practical teaching with cadavers, bone material, and histology slides, and because they are not that much interactive and informative. Despite the instructions of IT specialists in our faculty, in our opinion, the proposed option to use communication with students through social networks did not prove to be effective enough. This forced each department to decide on how to provide educational information to students. Most of the lecturers from our department, on their own initiative, began to implement various available platforms for online communication, in particular using Zoom video conferencing platforms for live delivery of the lectures. This proved to be an excellent tool, as it was possible to interact with students in a direct and quality manner. We were able to easily share videos and content to our viewing students. However, the free versions of this feature allows conferences of only up to 40 minutes, after which we had to leave the virtual environment and make a new video call. This discouraged students and sometimes waste a lot of time until everyone was able to rejoin. Alternatively, one has to pay with own funds the subscription. We then choose to use Skype for the seminars with students in small groups, as the conference time is not limited on this platform. In order to verify the students' performance, regular assessments were made through Google Classroom. This was done so that the students felt more secure and comfortable answering the questions. This evaluation methodology proved to be efficient, as it was possible to establish a secure connection and closer contact between teachers and students resulting in successful learning. The adopted adjustments were implemented in order to continue education in virtual classroom as an alternative method, but concurrently, they restricted teaching practices in the dissection room and histology laboratories. Indeed, online platforms can act as useful and effective tools for electronic tutorials in anatomy. However, we are convinced that this is not the most effective way to teach anatomy at a medical university, but it is the only alternative at the moment, and the current circumstances require this way to continue in the new academic year. Currently, the university provides access to the Google Classroom in an attempt to minimize the damage caused by the interruption of practical classes, indicated that this adjustment should continue. In conclusion, the pandemic is creating a new chapter in the history of medical education in our university and country. The new challenges to online anatomy education during the COVID-19 pandemic include issues related to time management, use of technology tools, students' assessment, communication, and the lack of personal interaction. Yet, this new reality may be a stimulus for medical universities in the country to adopt new technologies that facilitate teaching in the near future. For example, human anatomy learning system using modern three-dimensional anatomy software and other e-learning tools. Despite these challenges, online education has some benefits for students, administrators, and teachers. We believe that the COVID-19 pandemic will lead to wider acceptance of online and technology-enabled education, as it has boosted our confidence in the effectiveness of online medical education. To improve it, we should focus more on the improvement of infrastructures to train teachers and motivate students. I'm convinced that sharing our experiences and ideas about teaching factors that can determine practices and identify solutions to these issues that can be employed by all members of the anatomy community. This is so because in the future, online education will be complementary rather than an alternative to traditional classes. Good teaching would always be good teaching, whether it is face-to-face or in a virtual environment. Thank you.
Now, Dr. Sivko from the Medical University of Plovdiv will share their experience. And I will share the screen. Please.
Dear Mr. Chairman, dear colleagues, I'll try to be short, but I hope clear enough to understand the major issues that we have to deal with in this new environment created by coronavirus. Whatever we do, whenever we do, and however we do, we should bear in mind the most important thing. We have to be responsible for the students, for the teaching, for the knowledge. So the first thing that we have to ensure in this environment is the information about the new situation, about the coronavirus. So we created a new vision concerning the new teaching process in the new circumstance. We have the new recommendations done for prevention and control of coronavirus. It's essential to to prevent the students and all the teachers from the disease. That's why this is the first thing to be considered. Corona disease pandemic should be well presented and explained to anybody. We have not to skip this. We uploaded a handbook of coronavirus, COVID-19 prevention and treatment. We have important anti-epidemic measures that were also uploaded and information and recommendations. You see the website and how this could be found from anywhere and from anybody. I think this is the first to start with any teaching process. So we have to change abruptly, immediately in March, from one in-person teaching face-to-face without any preparation to the other one remote teaching. The first was 90% on campus, and the new one was 90% online. This is a great challenge, but we will cope with this. So we saved the semester, saved the year of the students. This was the most important. Now we change from this remote to hybrid courses, where we alternate online and on-campus classes. Almost half. All the lectures are online, of course, and the classes change from online to attendance. The major strategies that we outline are first to engage the student as partners. The student will not be only listeners to this remote teaching, especially during the lectures. They should be partners and should be engaged all the time. For example, students should be asked to present their own lecture during this process, to present their own practicals, to organize them. So this is important to keep them in this teaching process. The lectures should be delivered in interactive models. Assessment should be also reconsidered, and we did this safety net policy. And open book exam is a new method of assessment. First, we started with this, and then I repeat, healthy group work. We have to reduce the number of students when we have attendance classes, no more than 12 or 13. We also have to increase the space, so not too many students in one room should be taught. That's why we changed the program, the schedule, and now we need more space for less students. Of course, we did stations. This was mentioned by the previous speakers. I'm not going to repeat this. The same things. Stations are created in our department. In each station, different work is done. Feedback is important. This was ensured. Timely feedback. The students are always supported anytime online. Even now, the students can call us and ask for any help here. So the resources. Microsoft Office 365 was used for our distance learning. For 2 months, this was prepared instead of 2 years. Normally, all the process that should happen needs much more time than 2 months for this process, teaching process. So the platform is Microsoft Office 365, and all the university email addresses of the students and teachers are input. Microsoft Teams is used to ensure the classrooms, virtual classrooms. Any practical, any teaching, lectures are done within this classroom. So active written and audio communication is done between the teacher and the students during each practical, especially during the previous period when the semester was totally new. The resources are quite important. We rely on our library. It's one of the best in the field. We have a certificate of excellence for this library in the competition Best University Library. So this library ensures reliable online remote access to any teaching material. Trusted health science education is ensured by the library. The students can access any field of the discipline of the medicine, dental medicine, and other specialties from their own pace. Interactive online access can be ensured with essential texts that are provided. And online learning by being able to link to curricula and including valuable multimedia assets are also ensured by the law. So library is essential for any university. One of the things, the keystones in any university is the library. Here are some of the subject areas that are included in this process of teaching, remote teaching. Item interactive anatomy, access medicine, pharmacy, dentistry. I'll stress on the first one, and the next slide will expose, outline the item interactive anatomy. It's not a new, but we are subscribers to this have been subscribers for this for 6 years. One of the few in Bulgaria. So, item interactive anatomy ensures dissection, virtual dissection, ensures atlas, and 3D anatomy, clinical illustrations, because anatomy should always go with clinical cases. Encyclopedia, the terms I explained there, translated into English for English students. Curriculum can be made there. Anchor course test can be practiced all the time. One of the best teaching resources, anatomy interactive, and this anatomy interactive anatomy. The other things that we widely use in the department is sector educational portal. Sector portal allows to store and share knowledge, share educational cases with our students and other residents. Cloud-based sharing portal gives access to extensive library of cases. A lot of cases are uploaded there. All the time these are renewed. Even we can upload our own case there. Through this sector network, cases and knowledge can be shared within and between the university, not only within our university, but also between universities. And the sector table is an essential tool that we use that can prepare cases, that can ensure virtual dissection. This can be done in a remote manner. But I think that the students are widely attracted by this method of teaching because technology is closer to them than to class. Sector table is a quite important tool that we rely on. The other important thing is the simulation center, the only one in Bulgaria. I think the only one in the southeastern Europe that is certified by the International Surgical Association in USA. So in this simulation center, it provides for undergraduates, postgraduate, and PhD students knowledge courses, terabyte. This is used for laboratory practicals in different specialties and also anatomy. We use this in our course of clinical anatomy. Last year and this year, this should be incorporated in our course of regular course of anatomy. So from the very beginning, students should start with the clinical experience and knowledge. So this simulation training center is organizing practical sessions, and it's now part of the curriculum or specialty schedule. Any specialty can be scheduled there, and also we are part of this now. So the conclusions, major disruption was caused, of course. Face-to-face method is the best one to teach any specialty, not only anatomy, any medical specialty. So it's quite different from any other teaching, any other specialty. Anyway, we have to cope with this. We have to do something new because the environment is new. A huge effort was made to move all face-to-face activities to online. Tremendous effort, but we succeeded in this. The current use of technology for medical education is not yet reaching its potential at all. We have to improve this, and we have to improve our knowledge, become much better. The lack of the faculty development is also another problem. So the resources should be upgraded, and we need more skills to be attained, to be acquired. That's why it's a problem that should be coped with this regularly. And as whole, I want to mention that the major issue in this new environment is first, keep the health of students, then to keep the knowledge in proper way. So we have to present knowledge that is reliable, because the future medicals should be well prepared to work with live patients. Thank you.
Thank you. Then the next talk will be by Dr. Moreno from the Medical University of Pleven. Please.
Dear colleagues, let me share with you our problems, challenges, and our experience with teaching anatomy in an online environment. The global COVID-19 pandemic and the national measures taken to combat the spread of the virus have caused serious difficulties in providing opportunities for education and teaching. The unusual situation forced us to abruptly adapt to a new style of communication with our students. Our department was not prepared to face such a rapid change. In a short period of time, we were forced to adapt to online learning and teaching. This is how our distance learning website looks like. Here are all faculty and all disciplines. The platform we used were Zoom, Google Classroom, Microsoft Teams, and Virtual Classroom on our website. They all had different advantages and disadvantages. With time, we started to prepare the study material in a form suitable for online teaching. Some of the difficulties we faced was the lack of teaching staff, lack of enough competence and confidence while working with various electronic devices, lack of high-speed internet not only for us but for our students also, lack of computers equipped with cameras, microphones, and headphones, lack of electronic atlases and textbooks. Having to teach online disrupted the natural learning process, abruptly burned the teaching staff, and necessitated flexible and rapid adaptation. This is how the form of discipline looks like. By this way, we inform our students for classes, for topics, and in a short period of time, we managed to digitize our histological collection and publish the images in the manuals used by our students. In order to report the presence of students, we prepare tests covering material from the practical classes and for the lectures also. The e-learning coincided with the body dissection cycle, which turned out to be the most difficult challenge also for us and for our students. All of us acknowledge the enduring importance of classical methods for studying anatomy as a natural science. The lectures, topographic regions, diagrams, and images we used most definitely helped, but they could never replace the practical experience gained during training in the dissection hall. The pandemic measures forced upon us by COVID-19 necessitated that we move to a hybrid teaching program, a combination of lessons taught in attendance and online. Because of that, Medical University Pleven offers its students the learning platform Lecturio, which contains a lot of interactive models, video lectures, many questions to quiz the students' knowledge, and a lot of clinical cases. Since the beginning of this year, Medical University of Pleven and our department has begun using a virtual microscope. We have started making our collection of histological slides available for all our students. Last but not least, I want to invite you to the 15th National Congress of Bulgarian Anatomical Society, which will be held in Pleven in May next year. Thank you for your attention.
Thank you. So I will make a very brief talk about our experience here in Varna during these Corona times. So what we, I put this slide for the discussion, but we already discussed this in some part during the first presentations. How the obviously difficult situation can bring us to use new tools that would help in the future when this pandemic is over. I think this is one of the long-term messages that we should carry, that this difficult situation gives us an opportunity for the future. So here is the summary of the COVID-19 epidemic in Bulgaria since March. Initially, we had very few cases until middle of June, and then we had a peak during the summer, July and August, most probably due to the increased tourism. Bulgaria is a touristic place during the summer. Then the cases decreased, and now there is some kind of plateau in September, which is around 25 per 1,000 population per week. So we had in some parts 50 or more than 50. Now it's half of that. And in this situation, we start the academic year. Now in March, what we did about the lectures was not so much different from anything else. The difference technically was that we used a platform that we have already since 2013. So this is a learning management platform that combines both the material that can be uploaded, including PDFs or videos, the electronic tests, the electronic workbooks, the electronic marks and everything in one system. And this also included virtual classrooms, which work pretty much as a WebEx or Zoom meetings. And we did the lectures in this way, where the lecturer shares the screen, the students have a chat or can speak, and there is also online polling. Ronald showed very interesting ways to do this polling. In the Blackboard system is just included, so you can create a poll and students click in real time. And for the macroscopical seminars, we had to use as much as possible some 3D models that we had, again loaded in Sketchfab, and then transferred the link to the Blackboard and some presentations. And obviously one major challenge for the future is to have in a cloud comprehensive three-dimensional, especially using virtual extended reality product that can replace for some time real classes if there is a situation like that. We have one such a device, one such software, but it's only available in the classroom, so it's not in a cloud. What we had in a cloud was the virtual microscopy. We have developed in the last 5 years virtual microscopy platform that uses the high quality scan of our virtual slides that we use for the on-site seminars, but this is transferred online and is available via our custom platform that is very similar to the Google Maps. So it shows you under high magnification only the part of the whole slide which you zoom, and this is made by us for our slides, so it's identical to the slides that we show in the microscopy room. But in this case, we couldn't have a microscopy seminars in March, April, and May, and we did the online sessions with the students where they can zoom through these slides at their maximum. Also, there are annotations of these slides, like you see here for the spinal cord. So the annotations exist as a separate level on top of the image. So when the cursor comes on top of an arrow here or some kind of zone, you can draw an object. There is a pop-up window which shows you the name of this part of the slide. And so this was basically until the end of the semester. But the new thing we experienced for the first time was the distance testing. The students were at their homes for the exams in June and July. So we used a system for electronic or online proctoring, not having the students to be proctored in our computer rooms. We had to cover the whole material, so to create tests that are computer-based and cover the whole subject. Then the online proctoring took place via to the Blackboard system, which is a lockdown browser that it has to be downloaded in advance and tested by each student. So we had to do such pre-test sessions where we advise the students how to download and to troubleshoot. And during the exam, this platform also allows the so-called real-time monitoring of the exam session. Here you see in the lower part how this looks in the learning management platform. One of the tests has been linked to this lockdown browser and the monitor. So that's why here we see that this is required. The use of lockdown browser is required. So the lockdown browser leads the student to the test, and it can open only one link. Other links are not possible to open. The browser kills during the startup process all the softwares that can be used for chatting, such as Facebook Messenger, Zoom, and others. Then the student must use their own camera and microphone, which are built in the laptop or which are separately installed. And there is a webcam check, photograph, some additional instructions, a check of the environment where the camera should be rotated in all the directions to see what is around the table where the student takes place. And then the student takes the test. At the end, the teachers receive this report in the learning management platform, where some students have a high priority. So the videos, the generated videos are first checked by an artificial intelligence software, which gives to some high priority or some low priority. But then the teachers themselves have the whole video and check especially the high priority and high priority areas. These flags here are indications where some irregularities might have occurred. And the final output of this is whether the test is cancelled or not. Otherwise, the computer test gives you the score immediately. However, these challenges that I pointed here showed us that, for example, it takes more time. It's both for the students to wait a few days later and for the teachers to check additional videos. Already on the internet, once we start using this, we also checked, and the students have surely checked, that there are a number of cheats for this system available. There are forums where people describe how you can cheat the system, like any other software. So our conclusion is that a single camera, like the camera that I'm using now when I'm talking, and that shows me in front, is not enough. And only if you have a second camera or a mirror or a couple of mirrors on your back to show behind student environment can at least partially compensate for the fact of not having two cameras. And that is very challenging because it will create additional videos that need to be checked. So electronic proctoring seems to be useful in the short term, but we would prefer to have our students being proctored in our testing course in the future. And as a conclusion, I put several points that come from our experience. First is like the virtual microscopy platforms are available. Some are even free and can be used online, like Carl showed, or one can make their own, like we and many others have done. But in the 3D anatomy, there are so many things on the market, as discussed with Scott, in so many models in the Sketchup. However, cloud-based complete anatomy with virtual reality would be a real challenge. As I discussed, we have something that is available with virtual reality in the classroom, but when you have a pandemic situation, you need to have this virtual reality from in a cloud. Then the exam safety, like I said, online proctoring has certain challenges, and yeah, maybe the introduction of some international, I would even say international criteria, because medicine is a regulated specialty. So the way proctoring is done during the exam is quite critical, actually, and it's an important part in the licensing process. So I complete here. We are already quite ahead of the time with this session. So we shall make now a break of 30 minutes. But before that, if some of the speakers would like to say some concluding words for this medical teaching. I think we had several points. One is that teaching in electronic environment is quite tiring and takes a lot of resources. I think the other points that I made for the virtual reality in a cloud being available for the proctoring of exams, especially distant exams in medicine, and the safety of this is an important point. And yeah, I think some of the tools we learned to use during these last few months would be useful in the future. There were some very important messages that we learned, but let's see what is still going to come. Ronald.
Anton, thank you very much for organizing this symposium. I found it very interesting. It's obvious that all teachers in the world are in a similar situation, and all the world's students as well. And so I think it was very useful to share experiences and also to notice that we have similar experiences, but also nice to receive tips and tricks. I think sharing these things in for us a very new era is very important and also stimulating. So thank you very much. And thank you all participants.
Thank you, Ronald. Thank you all participants of this session.